Good afternoon, everyone. I'm going to open the next session with our first speaker, Dr. Jennifer Enger. She is a board-certified female pelvic medicine and reconstructive surgery expert who has dedicated her career to improving the quality of surgical care for patients with pelvic floor disorders. She is the only physician in San Diego who performs gender-affirming pelvic surgery and non-binary options. Dr. Enger is Professor of Urology and Vice Chair of Research in the UC San Diego Department of Urology. She leads the new program in gender-affirming pelvic surgery and is part of a large multidisciplinary transgender care team which provides comprehensive care for both adults and adolescents. She was the Assistant Professor of Urology at UCLA until 2010, where she gained expertise in robotic-assisted pelvic floor reconstruction. She then joined the faculty at Cedars-Sinai Medical Center to build a residency program and directed the ACGME-accredited Cedars-Sinai Fellowship in Female Pelvic Medicine and Reconstructive Surgery. She is dual fellowship-trained reconstructive urologist. She spent her first fellowship with Dr. George Webster at Duke University Medical Center, followed by a second fellowship at Urological Health Service Research, where she completed a master's degree in public health. So we welcome Dr. Jennifer Enger this afternoon, and she'll be talking about predicting recurrent UTI and interstitial cystitis using urobiome. Thank you.
Thank you so much for that lovely introduction. And I just want to confirm that you can hear me. You can hear me, yes. So I'd like to start with just talking a little bit about the differences in prevalence between urinary tract infections and interstitial cystitis or painful bladder syndrome, as well as differences in prevalence and presentation, and then talk a little bit about what we know about the microbiome in both these conditions. We know that acute cystitis is highly prevalent, and 60% of women will have an episode of cystitis in their lifetime. 20 to 40% who have an episode of cystitis will likely have another episode, and many of those, up to half of those, will have multiple episodes. What we see in practice is that overuse of antibiotics lead to collateral damage. We see antibiotic resistance. We see side effects of antibiotics, in particular related to fluoroquinolones. And there has been a great push for antibiotic stewardship in this area. Now, on the other hand, prevalence of IC is much less known. It is much less prevalent. And we actually did a study looking at prevalence of IC, and this was actually in the Veterans Administration. The reason we used the VA healthcare system was because we were able to identify patients by a diagnosis code and then actually go into the medical record and confirm whether or not these patients actually had IC. And what we found was that, and what we did was we identified a patient as having IC if they had 2 different visits at least 6 weeks apart in which they had bladder pain. And just to review the diagnostic criteria for IC, it's evolved over time. It used to be a diagnosis of exclusion. It used to be diagnosed by potassium sensitivity testing. And what we found was that patients without IC had positive potassium sensitivity testing. And often you could have IC with some of these other, what we used to call exclusion criteria. And now the evolution of the diagnosis of IC has simplified, and it now is bladder-centric pain, at least 6 weeks in duration. And that is the by the definition of by more than one specialty society. What we found that when we went into the charts, that patients who of less than half who had actually had a diagnosis of IC actually had IC by chart review. And by extrapolating to prevalence data in the US, we actually identified the national prevalence to be 0.9%, which is lower than what we've seen in clinical series, which approaches 2.7%, as well as the 0.05% in administrative studies, which is quite low. So even though IC is very low in prevalence compared to recurrent UTIs, they're related in several ways, partly because they present very similarly. So I want to talk about the fact that we have an AUA guideline which talks about management of recurrent urinary tract infections. And the reason I want to talk a little bit about the guideline is it just kind of helps us in differentiating UTI from IC clinically. So what's important here is an otherwise healthy woman with an uncomplicated UTI that's associated with acute onset symptoms. Now, this is very similar to a presentation for IC, but the difference here is that you have a positive culture in a patient with cystitis that's bacterial. The other distinguishing factor, which we can see with IC, but it's less common, is looking at dysuria, which is central to the diagnosis of UTI. Dysuria, burning with urination. Now, we see many patients do have similar symptoms to IC: suprapubic pain, urgency, frequency, new or worsening urge incontinence we see with UTIs. And we actually have shown that a high prevalence of patients with IC also have incontinence. But most patients with IC don't always have dysuria. And no patients with IC or an IC symptom flare should have a positive culture. What we found is when we use dysuria, it's to diagnose UTI, we have more specificity and are more able to differentiate UTI from IC clinically. What's important is that IC has many flavors, including some patients have flares in which their symptoms exacerbate, and they present very similarly to patients with a UTI. Whereas other patients with IC don't necessarily have flares. They may have constant symptoms or symptoms that periodically come and go, but don't necessarily flare in severity to a point where they're very disabled. So what's important in diagnosing a UTI is that the symptoms should occur with a culture in the urine. And usually for cystitis, we're seeing E. coli, Enterobacter, Proteus, Klebsiella, and many other possible bugs. And we're even seeing now more extended spectrum beta-lactamase producing organisms. So we're seeing more resistance in the community. When we're looking at treating UTIs, it's very important, and we've gotten away from self-start. We used to have patients who had their own bottle of antibiotics, and if they had symptoms, they would take them without a culture. And we've gotten away from treating over the phone without a culture. It's very important for UTIs that we treat based on cultures, and we rarely treat without cultures nowadays. I did go back in time when COVID hit and I had patients with symptoms. I started giving them antibiotics over the phone again, but obviously we were in a dire situation at that time. So so along these lines, we have to be very careful when we have patients with IC. We don't want to overtreat them with antibiotics either. And so we do need to make sure to get those cultures on those patients. So briefly, just to highlight some of the initial, in the AUA, American Urological Association guidelines, we have some basic guideline recommendations. So patients who have recurrent UTIs, and I like to translate this and say patients with IC should have a history and pelvic exam. In the case of a UTI, we want to make sure, do they have vaginal atrophy if they're postmenopausal? Are we missing something? And in the case of IC, where is their pain? Is it bladder in origin? Is it maybe pelvic floor muscle spasm, which is associated with pelvic floor dysfunction or what we call vaginismus? So we want that history and physical exam. And then to make a diagnosis of recurrent UTI, we need to document positive cultures. And why is this important? Well, we have patients with IC are often treated with multiple courses of antibiotics. And many of the time, if you, and it's not until they have a few different treatments with antibiotics and they found they were culture negative that they start getting referred for possible interstitial cystitis. So it's very important that when you have a patient with a symptom flare that we have a culture. Now, what we have seen in patients, when I trained a long time ago under Dr. Derek Kottmann at Cornell, and he used to say, patients with IC, remember the day that their IC started. And that actually is quite true to this day. And often they believe, or maybe even it does start with a UTI, we're not sure, but often they have a history of a positive culture. And we see probably that in some patients, they have a positive culture, they're treated, and their symptoms persist. And that's where we start thinking about IC, but also making sure we're not missing a resistant organism. And in this case, again, a culture is really important to help us distinguish those two. And so we need, again, diagnosing patients with cultures for both IC. Now, what do we do for patients who, when we suspect contamination, we get a catheterized sample? And it's very important when we have patients who also have bladder pain and may not necessarily have a positive culture. A catheterized sample is very important. A catheter sample is also important if we are studying the microbiome of these conditions, which is what I want to talk to you about next. And again, so here, this is a study that we did that looked at rates of culture-proven UTIs in women with an IC diagnosis. And I just want to highlight that as we know, the flares of a UTI are very similar to an IC flare, and a positive culture is really all we have to distinguish the two. So we looked at patients again in the veteran system because of this nice ability to go back and look in the medical record. And what we showed was, and this is a heterogeneous population, here you can see that patients in the black are patients who had a positive culture. Now, these are patients with symptoms. And on the right are patients who actually had a positive culture. So on the left, did they have a culture done at all? And what you see here is the patients with dysuria had a higher rate of positive UTI, but it was still very low. It was like 8%. So what this is showing is women with a diagnosis of IC and IC flares actually seem to have a pretty low rate of UTI overall. In these cases, it's more prudent to potentially wait for cultures before treating with antibiotics. So now I want to touch a little bit on the role of the urobiome in both recurrent UTIs and interstitial cystitis. We've had revolutionized the field with molecular testing technology, the most common of which are PCR, polymerase chain reaction, and next generation sequencing. Now, PCR can provide a rapid test, but that has to be based on matching of a patient's DNA to a small set of pre-selected organisms. So it's sensitive, but you need that causal organism to be in your panel. And whereas next generation sequencing takes longer, but can really analyze all the microbial DNA that might be in a sample. So they have different purposes. What we have seen is a lot of this is brought into practice, but it's important to know that patients with and without UTI, there is a good concordance of these technologies with culture. However, what we're finding is that patients who are culture negative also have E. coli in the urine by PCR, and we've also seen this with next generation sequencing. So the risk of these are that we can end up identifying bacteria which may not necessarily be pathogenic. And so that's why these technologies haven't made it into the new guideline yet for UTIs. And for when we look at IC, this is what I showed, a study that basically 21 of 22 asymptomatic controls were also positive for bacteria. So we have to be very careful about this. Now, briefly, I want to show you as part of the MAP network, which we were studying, which was a big characterization of patients with IC, we found that many patients on average had numerous species in, and these were in control groups. So we found that species and genera were very diverse in normals, not even in IC patients. Here you can see lots of species, more in women than men. Now, of note, the MAP network did not catheterize women, so these were voided samples. Here you can assess these measures of diversity, women being in the yellow, and you can see broader diversity in females compared to male, meaning more diversity of species identified. This was also work that we had done under my colleague Lenny Ackerman that showed in catheterized samples, fungal diversity was abundant. And these are in 13 subjects, and each color represents a different species. And this shows that there's diversity in catheterized samples of asymptomatic women, lots of fungal DNA. So we know that hormones that urine is not sterile, but what we don't know is what's DNA, what's commensal, what's live DNA, and what's pathogenic. So what we found was that the urinary microbiome in healthy people shows diversity. And gender differences are likely attributable to detection of urethral or vaginal organisms in women and prostate organisms in men. Again, a lot of the MAP network studies were not catheterized samples. But what's important is it's different to know, did the disease cause any effects of IC on the microbiome, or does the treatment? There is some showing of loss of diversity. So we think of diversity being healthy when you're looking at the at DNA patterns with next generation sequencing. And we've sometimes shown in some that there might be predominance of a given organism in a disease state. And what it looks like, but we know that patients with IC come in after having been treated with multiple courses of antibiotics. And so how did this antibacterial load impact the microbiome? Or is it the disease? Are Hunner's lesions, for example, in the bladder, due to a microbial dysbiosis? So that's a run through of a very broad topic, but I want to thank you for your time and I look forward to any questions.
Presentation. Are there any questions at this point in time? Okay, if not, maybe I can ask a question, Dr. Enger, with regards to the knowledge on the urobiome with effects on the interstitial cystitis or recurrent UTI. Are there any directions or your views regards to novel therapies then, knowing this knowledge moving forward, or the treatment or prevention of recurrent UTI?
Right now we're going by the AUA guideline. There's promise with cranberry, definite promise with estrogen therapy for postmenopausal women. We did a recent update of the guideline, which actually had one study that actually showed that methenamine is comparable to antibiotic prophylaxis, which is nice because I've used methenamine a long time, but it's nice to have a treatment that's actually supported by the literature now. With IC, I think where we're looking is in certain populations, like a Hunner's lesion patient. Is there something wrong with the urobiome that creates a Hunner's lesion, and can we better target that? I think that's some of the work that's on the horizon.
Thank you, Dr. Enger. What about your views on the urinary vaccine in the prevention of recurrent UTIs?
the data, so when we looked at the literature, it wasn't enough to be supported in the AUA guideline, which is rigorous. I mean, the AUA guidelines use a rigorous review, assessment of bias, and so we have not added that to the guideline, but it's definitely promising.
Thank you very much. Thank you very much for your time. If there's no other questions, we'll move on to the next speaker. Okay. So our next speaker is Dr. Jun Yun Shin. She is a graduate from the Ulsan College of Medicine and did her internship and fellowship at the Department of Urology at Asan Medical Center, Seoul, Korea. She's currently the clinical assistant professor at Ewa Women's University, Mokdong Hospital, and she will be delivering the UAA lecture on best practices and updates in the management of interstitial cystitis. Thank you.
Good afternoon. It's my honor to give a lecture in plenary session of UROFAIR 2022. My topic is best practices and updates in the management of interstitial cystitis. First, I, Jun Shin, have no conflicts of interest. Best practice is a standard or a set of guidelines that is known to produce good outcomes if followed. For interstitial cystitis IC, there are many best practices, and the most familiar ones are AUA guidelines, which has been most recently updated, EAU guideline, East Asian IC study group, and ESSIC criteria. To provide best practices in IC, diagnosis is important. There is no widely accepted definition. This resulted in creation of many confusing terms. So let's overview the definitions and diagnosis of IC in different guidelines. AUA guidelines define ICBPS as an unpleasant sensation perceived to be related to the urinary bladder, associated with loss of more than 6 weeks duration, in the absence of infection or other identifiable causes. Recommended assessment emphasizes evaluation based on symptoms and excluding other pathologies. Performing cystoscopy when hunner lesion is suspected is also important. There is no mention on type of cystoscopy, rigid versus flexible, and mode of anesthesia, liquid versus gel. In EAU guidelines, IC is included in subsets of chronic pelvic pain syndromes under the name of primary bladder pain syndrome. The definition is similar to that of AUA guideline, but there is no mention on symptom duration. The EAU guidelines strongly recommends rigid cystoscopy under general anesthesia to rule out completed disease and for subtyping IC. The ESSIC criteria uses the term BPS, bladder pain syndrome, and mentions disease duration of more than 6 months for chronic nature. BPS is classified with findings on cystoscopy, the presence of glomerulation, and herniation. The definition by East Asian IC study group also has no mention on disease duration. IC is classified in 2 subtypes, hunner type IC with positive hunner lesion on cystoscopy, and BPS, in other name, non-hunner type IC. Cystoscopy is mandatory to determine the presence of hunner lesions. Then, what is hunner lesion? Hunner lesion was first reported by Dr. Guy Hunner in 1915. It is classically defined as circumscribed red mucosa area with small vessels radiating from the central scar with or without chloroform. There has been no standardized atlas, and variation in cystoscopic appearances contributed to confusion. In 2020, Renfro et al. Suggested the first atlas of linear appearance of hunner lesions. There has also been an investigation on the association between clinical symptoms and various bladder lesions of IC. This study also documented different appearances of hunner lesions and associated findings. Some hair lesions had pale appearance, similar to that of tear scar, or highly inflamed erythematous appearances. Associated findings include waterfall bleeding, submucosal hemorrhage, which is traditionally named glomerulation, and recurrence of varying degrees. To sum up, all guidelines emphasize the exclusion of other pathologies that could mimic IC. Now let's move on to the treatment of IC. AUA guidelines have recommended chemotherapy for IC from first line to sixth line. In recent updates, the treatment is categorized into behavioral, non-pharmacologic, oral medication, bladder installations, procedures, and major surgery. I would like to introduce updates along with recent researches based on the AUA guidelines statements. Overall, the efficacy of treatment should be periodically reassessed to stop invalid treatments. And if there is no improvement in symptoms despite multimodal approaches, the diagnosis of IC should be reconsidered. Behavioral and non-pharmacological treatment includes self-care, behavioral modifications, and stress management. Patients should be educated the fact that IC is a chronic disease with no single effective treatment, and multiple therapeutic options are required in most cases. Peripheral strengthening exercise should be avoided, and appropriate physical therapy might be suitable for patients with peripheral tenderness. Oral medication includes painkillers, amitriptyline, cimetidine, hydroxyzine, and pentosan polysulfate. The updated guidelines suggest that clinicians should counsel about the potential risk for macular damage and vision-related injuries associated with pentosan polysulfate. Pentosan polysulfate maculopapular was first reported by peers in 2018. 6 patients with median exposure of 186 months with cumulative dose of 2,260 grams of pentosan polysulfate presented with pigmental maculopathy. The patients have difficulty in reading and prolonged photoadaptation. The possible mechanism of action was antagonism of fibroblast growth factor signaling in retina. Since then, there has been many reports on PPS maculopathy. In 2021, a review on 2275 reports on PPS compared proportion of any adverse event on eye with 6,833 reports on other drug-related IC. Proportional adverse events for any macular event was 1.2 times elevated for PPS users. Although controversial, there has also been a report on possibility of maculopathy evolution after PPS suggestion. Agents for intravesical installations for DMSO, heparin, lidocaine, chondroitin sulfate, hyaluronic acid, pentosan polysulfate, etc. The available agents might differ among nations. For example, in Korea, DMSO is not available. The problem with intravesical installation is there is no standardized installation protocol. Procedures for IC include hydrodistension, perforation and honor lesion, Botox injection, and neuromodulation. Despite no standardized protocol for hydrodistension, a short duration low pressure is undertaken as treatment option. Laser has been excluded from the modality for perforation of honor lesion. A randomized control study by Code suggested that there is no difference in efficacy between resection and coagulation of honor lesion. However, the problem with removal of a honor lesion is risk of recurrence. The recurrence rate was approximately 30.7%, 40%, 50.2% at postoperative 6, 12, and 18 months. In addition, the recurrence patterns of honor lesion is unpredictable and involved both previous coagulation site and de novo areas, which suggests that IC is a disease of whole bladder. Intra-detrusor Botox injection and neuromodulation can be also considered if other treatment did not have adequate improvement in symptoms. The problem with Botox injection is that many studies simultaneously performed hydrodistension after Botox injection, with various injection units, sites, and number of injections. For neuromodulation, there has been a limited number of recent studies in IC patients. Major surgery is the ultimate, final, and most invasive option, but this should be used at the last therapeutic result. Major surgery includes augmentation cystoplasty, urinary diversion with or without cystectomy. Whether or not cystectomy should be performed at the time of urinary diversion is somewhat particular. For IC, there are treatments that should not be offered. These include long-term oral antibiotics, intravesical instillation of BCG, high-pressure long-duration hydrodistension, and long-term systemic oral glucocorticoid. These treatments appear to lack efficacy and have possibility to accompany unacceptable adverse event profiles. Due to the fact that there are no definite treatment modalities for IC, robust investigation studies are ongoing. Representative studies are stem cell injection and platelet-rich plasma (PRP) injection in IC patients. Currently, a phase 2A clinical trial with human embryonic stem cell-derived mesenchymal stem cell injection is ongoing by a study group of Chu in South Korea. There has been no stem cell injection-related adverse events in phase 1 study with low-dose stem cell injection of 18 months follow-up and high-dose stem cell injection of 4 months follow-up. The platelet-rich plasma injection study was actively performed in Taiwan. Patients who underwent monthly intravesical PRP injection had a significant improvement in symptoms. This diagram summarizes the best practices of this in management of IC. First, excluding other pathologies is important. For multidisciplinary approach for IC treatment, behavior treatment, or medication, intravesical instillation and procedure can be considered. However, patients who are about to take oral tamoxifen polysulfate should be notified about the potential risk of eye damage and vision-related injuries pre-treatment. In addition, if hormone lesion is identified, electroporation of the lesion with or without triamcinolone injection is recommended, but possibility of hormone lesion recurrence should be educated to patients. In cases of failed physical treatment, major surgery or investigation studies, aka clinical trials, including stem cell injection, instillation, and other experimental approaches could be considered. In conclusion, there are still controversies in diagnosis and management of IC, where current best practices might disappear or change in the future. But personal questions are: is hydrodistension necessary for diagnosis of IC? What is the exact coagulation range for hormone lesion to minimize the recurrence? What is the suggested follow-up schedules after hormone lesion coagulation? We need to standardize the protocols for instillation and procedures in IC. And how many times repeated coagulation of hormone lesions is acceptable? And what if major surgery fails? To solve these problems, robust investigations and best practices for IC is mandatory. Thank you for your attention.
Thank you, Dr. Jung, for the presentation. I think we all agree that IC is a condition that is very difficult to diagnose and very difficult to manage or even treat. It's a chronic condition. Are there any questions from the floor for our speaker? Okay, if not, I'm going to hand over the time to the next two moderators for the second section of this Recon and Functional Plenary session. So I'll hand over to Dr. Jo Lee and... Oh, sorry. Oh, okay, so sorry. Sorry, Jo. Yeah, okay.
Dr. Shin, are you still online?
Yes.
All
Okay, you hear me?
This is Dr. Lawida here. I'd like to check with you what are the treatment that's under investigation by yourself and at the moment in Korea for the management of IC, any investigative therapies?
Currently I am working with Professor Chu I'm currently investigating stem cell injection.
What
Can
is
you hear
the?
me?
Yes, we all can hear you. I'm just wondering how's the presently, what are the results like, and what is the potential of this kind of treatment?
Okay. Currently, as we are using human embryonic stem cell derived mesenchymal stem cells, first we finished the phase 1 study and we found that it was safe. And now currently we're working on the higher dose on 2A, phase 2A, and I think in short-term follow-up there is some effect. The pain is decreased, and on cystoscopic follow-up, the honey lesion, the small ones, less than 5 millimeter, they just disappear. So, but maybe we need to look further on the long-term follow-up. I think that stem cell injection might have some promising results.
Lecture. Can I ask you if any experience with intravesical pentosan pentasulfate?
Intravesical instillation of pentosan polysulfate. Currently, we are not exactly using pentosan polysulfate for intravesical instillation. In Korea, hyaluronic acid, the hyaluril, is available. So we are just using to some patients with refractory or recurrent symptoms. So my experience with hyaluronic instillation is that once we do the perforation or hydrodistension for IC or BPS, the extent of multiple bleeding or the bladder is very not that good condition. So I just recommend patients that maybe hyaluronic instillation might prevent the recurrence. So I instillate the hyaluronic with weekly for 4 weeks, two bi-weekly for 4 times, and about 8 times at a time.
Thank you.
But I think it is so effective in some patients, but not that promising.
Okay, thank you. Thank you, Dr. Jung. Thank you for your time. Thank you very much.
Good afternoon. Dr. Jolie from National University Hospital. I'm moderating the next session for reconstruction with Dr. Tricia Kuo from Mount Elizabeth. So our next speaker, we'll do a combined Q&A after the next two speakers have spoken. The first speaker, Dr. Pak Si, is an Indonesian urologist from the Saiful Anwar General Hospital. He's experienced and established a referral center in genital urinary reconstruction surgery in Indonesia. And in 2016, he was also appointed as the secretary of the Indonesian Genital Urinary Reconstructive Society. He'll be speaking on the topic of versatile utilization of buccal mucosa graft in genital urinary reconstruction. Right, Dr. Pak Si?
Good afternoon, Singapore. Greetings from Indonesia. I'm Paksi Satyagraha from Malang, and it's a great honor for me to be here to be part of such a prestigious meeting, UROFAIR 2022. Unfortunately, still this time we could not meet each other in person, but hopefully when the time is right and everything is better, I could meet you personally. So thank you very much for the committee who has invited me to be part of this great session. There is no disclosure in my presentation, and today I'm talking about the versatile utilization of buccal mucosal graft in genital urinary reconstruction. I'm from Malang, the second largest city of East Java province. It's a very beautiful touristic destination, and I welcome you here to my city and have a good time. We have a 900,000 population, and I'm working in a government university teaching hospital with 900 beds. We are one of the urology referral center in East Indonesia, and we have conducted a national and also international meeting in GU reconstructive surgery, in genital urinary reconstructive surgery. Thank you very much. I would like to also send my gratitude to all my mentor and friends from Kulkarni Endo Surgery Institute, India, Pune, and also from Indonesian Genital Urinary Reconstructive Society. So, before we talk about the versatility of buccal mucosal graft in a reconstructive surgery, let's take a look about the history of oral mucosal graft usage in urology. Initially, basically, it's not the urologists who perform substitution with the buccal graft, but in 1873, the first use of oral mucosa as a substitute material in surgery was from Austria by Dr. Stelwak von Karajan. He's an ophthalmologist who used a lipocosa to treat conjunctival defect. But in urology, the first person who reported, even it is in a Russian scientific publication, Professor Kirill Sapesko from Ukraine, he used the first oral mucosal graft as urethral replacement. He performed two-stage urethroplasty, and this work continued by his fellow, Dr. Timos. He's using urethroplasty for using oral mucosal graft for his urethroplasty. And years later, Professor Graham Hamby, he reported an English written publication. He reported a successful hypospadia repair following failed previous hypospadia repair. So this is quite important. And the next publication would be from many other colleagues, like Berger conduct the first experimental study in animal. He's joining his research with oral and maxillofacial surgery. And then DeSanti also reported using oral mucosal graft for hypospadia repair. And this Hamby and DeSanti report is basically one of the milestones of the use of the oral mucosa in urology. Meanwhile, for stricture, the first report in adult by El-Kazabi is the first report use of urethral stricture in adult stricture patients. There are so many different types of substitution used in a georeconstruction other than the buccal mucosal graft. There are genital and extragenital skin, but the problem is genital skin is vulnerable to lichen sclerosus, also vulnerable to keloid formation. Other donor part of the graft is bladder mucosa. The characteristic is similar with urethra and a buccal mucosal graft, but the problem is if we want to use this tissue, it's just becoming more and more invasive to open the bladder and then take the mucosa and close it up. So we basically don't do bladder mucosa graft. Other are lingual. This is my second choice rather than the buccal mucosa graft. But the problem is it also has this advantage, high morbidity, post-operative pain, and also could cause speech change and difficulty to eat. This is my second choice compared to buccal mucosa graft. Other more invasive technique is colonic mucosa. It requires sigmoid resection, and of course, it will be more complicated and complex procedure. Why buccal mucosal graft? There are so many journals, papers talking about why buccal mucosal graft. The point is, it has a thick epithelium, high content of elastic fibers, and rich vascularity. And this is basically buccal mucosal graft is easy to obtain, easy to manipulate, and basically less invasive technique. I will show you how I harvest the buccal graft at the end of the lecture. It also gives a lower morbidity and post-operative complication. It has a wet epithelium. Basically, it's similar to urethra and all the urinary tract epithelium. It also has excellent immunity. It increased the amount of IgA for better healing and resistant to infection. So mostly buccal mucosal graft is used for stricture repair. Since the old technique of flaps are now changing to so many graft techniques, two-stage technique are now shifting to one stage, and there are so many different types of minimal invasive technique, musculovascular sparing surgery, like cold Kearney technique. These are four fundamentals techniques using buccal mucosal graft to treat urethral stricture disease. In 1996, Guido Berbagli introduced the dorsal-only buccal mucosal graft, and then in the same year, Professor Jack W. McAninch and Alan Maury also introduced the ventral-only buccal mucosal graft. An inlay technique was introduced by Professor Asopa from India, the dorsal inlay buccal mucosal graft in 2001. While at the end, the latest technique was performed by Professor Sanjay Kulkarni from India with one dissection buccal mucosal graft repair. This is our algorithm of management for urethral stricture disease in Indonesia, divided on anterior and posterior, traumatic or non-traumatic. So the non-traumatic could be could be done with buccal mucosal graft with so many different types of techniques. These are the dorsal-only technique introduced by Guido Berbagli. He mobilized the whole bulbar urethra, put the dorsal patch, quilt it, and then suture it from the lateral side. It also there are also some different modification. It could also modify to be a double-phase buccal mucosal graft. So it's like this one. It's dorsal only and ventral inlay for a quite severe and obliterated stricture. While this is the ventral onlay, I use this technique a lot if I want to do an intraluminal surgery. I don't want to jeopardize the sphincter, especially for post-op strictures. This is the technique that I normally do. And a SOPA technique, dorsal inlay, it puts a graft inlay and then tubularized. These are the technique that we use mostly for the second stage urethroplasty due to hypospadia repair that was failed. And this is also the one-side dissection dorsal onlay mucosal graft that was introduced in 2009. So he basically dissect only from the right side of the urethra. So this preserved the muscle, the vascularization, and also the nerve of this area. So the goal is to preserve the lateral vascular supply to the urethra. These are the modification, double phase, whether it's dorsal or dorsal onlay, ventral inlay, or dorsal inlay, ventral onlay. So this is just the modification of those four techniques. And then for difficult or more complex condition, we could also combine the flaps and graft for these cases. For example, long bulbar urethral necrosis, because this patient doesn't have any bulbar urethra left due to the vasculogenic problems of the urethra. So we do dorsal onlay and also ventral tubularization of the penile skin. So this is what we do if we have to recreate the new urethra for the whole bulbar side. This is what happened after 4 weeks or 6 weeks after surgery. Patient is good. So our experience only in 3 years, a few years ago, 3 years we do 168 urethroplasty with 83 augmented urethroplasty. Mostly is with the dorsal onlay one-side dissection technique, and the success rate is around 90%. So what is the versatility outside the stricture repair? How is it? So many reports. In 2020, our colleagues from Germany reported open urethroplasty with a buccal mucosal graft for long proximal urethral stricture. So they have quite a good result, 75% of success rate in 4 patients. Basically, they repair this segment of ureter. They place the buccal graft in the omentum as a neovascularized bed, put it as an onlay, and then and suture it lateral. And then these are the results after 4 weeks, and 1 year follow-ups shows a very good results. There are so many other reports using buccal mucosal graft. For example, we could do a gland-saving urethroplasty, gland resurfacing, and also vosonavicular involvement. Also, buccal graft is used for the Peyronie disease, and then also buccal graft is also performed to reconstruct the refractory bladder neck contracture, whether with open surgery or robotic surgery, with a success rate varies about from 88 to 100%. These are the example of penile resurfacing surgery by buccal mucosal graft. What about lower urinary tract repair? In hypospadia, there are so many different types of report using a buccal mucosal graft as the treatment of choice rather than using a penile skin or percutaneous skin, since I've mentioned before that this hypospadia repair is initially popularized by Hamby in 1941. Professor Braca also introduced the 2-stage repair with a buccal mucosal graft, and it shows a reasonable outcome. This is a very nice paper from my good friend, Professor Đorđević from Serbia. He's the one who's introducing this technique, a dorsal onlay and ventral onlay for a ventral flap. So basically this technique could be used for a very severe hypospadia condition, and it shows a 100% success rate in 22-month follow-up. So they put a buccal mucosal graft in the dorsal part, in the bed of cavernosa, and then they put a longitudinal penile skin flap and put it as a ventral urethra. So this is how they do the urethroplasty. It is severe cases, and they reported with a good results. What about the future? For me, robotic surgery is still in the future, because basically robotic surgery is not commonly available in Indonesia. But Li Zhao, our good friends from the United States, he did a urethral stricture with a buccal mucosal graft rather than doing an open surgery. And basically this technique could give the patient a less invasive surgery, less blood loss, less pain, and gives a better cosmetic outcome. This is how we did the port placement and also the patient position. And basically, he put a buccal-mucosal graft after he incised the urethra longitudinally. He put the graft in the omentum and put it as an inlay and onlay, and then wrap it with omentum as a neovascularization bed. A very nice report, a very nice result. Another technology is reported by Guido Barbagli in 2019. He reported Mucosal, a tissue-engineered oral mucosal graft, and he has done it to the stricture patient, anterior stricture patient, and the success rate between the real oral mucosal graft and this tissue-engineered urethroplasty is similar. But the problem, I don't know whether it is going to be our future, because this technology will definitely cost so very expensive. This is what he do, an anterior stricture repair, and the follow-ups is reasonable. Another advancement or another research was performed by my very good friend from Syracuse, Dr. Dimitri Nikolavsky. He introduced the novel concept of treating a buccal-mucosal graft using a liquid buccal-mucosal graft. So this is basically an experimental animal experiment procedure. So he took the buccal-mucosal graft, he rinsed it, he combined it with vibrant glue, and then he sprays it in the urethra, and then he looked at 24 weeks. He reported a reasonable outcome, but maybe I don't know whether this is going to be applicable in the near future. We just have to wait and see the future result of this research by Dr. Nikolavsky. So many different types of technique, so many different types of experiments, but this is how I do my buccal-mucosal graft harvesting. These are the instruments that I use. The mouth retractor, so I put 2 stitches as a stay suture, identifying the Stenson duct. So normally it is in the proximity of second molar, and then I drew the lines. I designed the graft. If I need a very long graft, I normally try to do 2 or 2.5 centimeter wide, and we could take as long as possible proximally. We inject hydrodissection with lidocaine and epinephrine to decrease the bleeding. Another stay suture inside. Then after we have this, then we started to incise the mucosa. So this is a very important thing, to divide or dissect in the proper plane. So we should not take muscle. We go further from the muscle and stick to the buccal mucosa. And we could basically take a very long graft. I normally can do 8 to 9 centimeters of buccal mucosal graft if we want to repair a 17 or 16 centimeter of penurethral stricture repair. So it's very it's available for such a long stricture. So after that, we defat the graft and ready to use. So that is the way I harvest my buccal mucosal graft. So in conclusion, buccal mucosal graft is still the choice for tissue donor and have a very wide versatility for its use in urology. In the world of urethral reconstruction, buccal mucosal graft is the gold standard tissue. My second choice would be the lingual graft. And nowadays, the advancement of many surgical techniques, robotic surgery may play a key role for minimal invasive surgery in the world of reconstructive surgery. And there are so many experiments and also research about tissue engineering, tissue culture. Liquid buccal mucosal graft might be the future, but we still have to wait for the further result and report from our colleagues who concentrate on doing this research. Thank you very much for your kind attention. Once again, thank you very much for UROFAIR, the scientific committee who has invited me in your prestigious meeting. I hope I could see you again soon in person. Greetings from Indonesia. Thank you for my residents, Dr. Bo, Dr. Dipta, who helped me to create this presentation. Good afternoon and bye-bye.
Okay. Okay, so we'll be taking questions for both lectures at the end of the next lecture. So I have the great privilege of introducing Dr. Kodi Nagapan, who will be giving the lecture of Female Urethral Stricture, Can We Do Better? Dr. Kodi graduated from the University of Malaya in 1999 and completed her postgraduate degree in general surgery at the National University of Malaysia. She is a pediatric urologist with a special interest in women and children, and Dr. Kodi specializes in the diagnosis as well as medical and surgical treatment of patients with genital urinary tract problems. In addition to this lecture, she will also be giving the subsequent lecture of urological problems in adolescents. So Dr. Kodi, please take it away.
Good evening. Thank you very much for having me here. In recent years, there has been some interest on urethroplasty techniques for women with urethral strictures. The outcome of these surgical techniques are heartening, and women now have the option of not having to undergo repeated urethral dilatation procedures by a urologist or painful urethral self-dilatation at home. Now, a quick PubMed search on this condition will show that the first reported case of female urethral stricture was in 1945 by R. Tauber. It was a German paper, and in this case, the etiology was sexually transmitted infection. Other early papers provide clues on what surgeons of that era considered normal female urethral caliber, which could be anywhere from 22 to 28 French. And there was also some clue as to the use of urethral calibration to diagnose urethral strictures in women. Now, by 1958, John Madden, an Australian urologist, published his case series of 5 patients. His patients presented with frequency and dysuria. He diagnosed urethral strictures by being unable to insert a 21 French rigid cystoscope. The etiology was gonococcus, recurrent infections, menopause, coitus, and catheter trauma. And his treatment was dilatation every 4 weeks and further dilatation as the patient required it. Now, in his case, the response 1958 response to dilatation was considered diagnostic of the condition. Now, from a historical perspective, this tells us that women have had urethral strictures for a very long time. And though we make progress at this point, what we need to understand that most of these conditions have occurred a long time ago, and we're just making slow progress in being able to manage this condition. Now, my own interest in female urethral strictures began in 2018 when I had a patient, a young woman, who came to me having undergone numerous urethral dilatation procedures and developed recurrent episodes of urinary retention despite self-dilatation. I was intrigued by a case report by Hogue and Chi, which outlined a ventral inlay approach, mainly because it was similar to the approach that I use for posterior urethral strictures in men. By the time I had operated on 3 such patients and presented my outcome, P. Nayak and his colleagues from India published their own case series of using the same technique on 13 women. Now, what can I add to the existing knowledge is how I select my patients and how I ensure good outcome in a low volume setting. Now, whom would I offer urethral, considering the difficulties of making a diagnosis of urethral stricture in the first place? I would offer surgical intervention to women with poor urine flow or urinary retention, a box flow pattern on uroflowmetry, a consistent etiology, whether it is catheterization during a previous cesarean section or recurrent infections or menopause, and patients who have had prior urethral dilatation. Now, the initial step is always diagnostic cystoscopy and urethral calibration. I use a 16 French cystoscope, and what I look for is obvious narrowing, whitish discoloration, flimsy membranous ring, rigidity, poor distensibility of urethra, resistance or inability to negotiate the scope. The following images show the typical findings that one may encounter during cystoscopy. On this side, what you see is a flimsy membranous ring. And you do see some kind of rigidity where, this urethra is snug around the 16 French scope. And you can also see flimsy membranes and whitish patches. Now, on the other hand, these are the type of patients to whom I would offer urethroplasty surgery. Here, in the endoscopic view, you can see a very tight urethral stricture. You can see pale fibrotic urethra, which is pretty distensible, and another stricture close to the bladder neck. Now, the urethra is always, once the urethra has been calibrated and the diagnosis ascertained, the subsequent steps of the ventral inlay urethroplasty include exposure of the stricture, incision of the stricture, getting the buccal mucosa graft from the inner cheek, attaching the graft to the bladder neck, and quilting the rest of the graft to the edges of the incision and the meatus. To expose the urethral stricture, the urethra is further dilated to 28 French. This allows a nasal speculum to be inserted. A bladder is emptied, and at this point, usually ensure that antibiotic has been given. Magnification helps. I use a 3.5 wide angle loop, and illumination can either be from a headlight or a light source. Now, at this point, as for the incision of the urethral stricture, I usually perform it at the 6 o'clock. And I ensure that the entire length of urethra from the bladder neck to the meatus is incised to sufficient depth. Now, how deep should you go? You can see in this cross-sectional image that there is the urethral mucosa, the submucosal venous plexus, and then this smooth longitudinal muscle. And as you can see here, I have incised this urethral mucosa until the smooth semicircular muscle fibers are visible underneath. Now, at this point, I would like to compare the ventral inlay technique to other approaches such as the dorsal onlay and ventral onlay technique. In the dorsal onlay technique, the urethra is incised at 12 o'clock position. The advantage of this technique is the ability to visualize the bladder neck clearly, but there is proximity to the clitoris vestibular bulbs, and quilting the graft on the clitoral body, I feel, carries a risk of female sexual dysfunction, which is never reported in any of the papers that publish outcome of such an approach. Furthermore, the lambda-shaped urethral sphincter is pretty close to this dorsal onlay incision, though there have been no reports of urinary incontinence after the dorsal inlay approach. Now, the drawings in this following slide highlight the proximity of the dorsal innervation of the clitoris as well as the vestibular bulbs and the lambda-shaped urethral sphincter to the urethra at 12 o'clock. Now, this image shows the ventral onlay approach, which involves an incision on the vagina. Now, this patient that I have actually underwent an incision in the anterior vagina for placement of a rectus fascia sling for stress urinary continence. So I'm just showing this picture to highlight the approach. Now, while this premenopausal woman has thick vaginal flaps, and this procedure is technically easier, and there may be less risk of stress urinary incontinence, there is the risk of urethrovaginal fistula when there is paucity of ventral muscular tissue of the vagina and the overlapping suture lines. Now, in my usual practice, I usually use the buccal graft, okay, this shows how the quilting of the graft is done. Now, the most technically challenging aspect of using the ventral inlay vaginal sparing approach is securing the buccal mucosa graft to the bladder neck. But it is important to ensure that that at least 3 apical PDS sutures are placed securing the graft to the bladder neck. I use an angled needle holder that usually doctors used to use in previous open prostate surgery. Now, in this image, what you see is that once the graft has been securely quilted to the bladder neck, the rest of the graft can be sutured to the edge of the mucosal defect and the meatus. And once that is done, this image shows this graft being quilted to the meatus. And then once the edges of the graft are secure, it can be quilted securely in the midline. Now, a full video of this procedure was presented last year at the Malaysian Urology Conference. But what we must remember is not all women with urethral strictures require a full urethroplasty. Now, I had a patient with a soft, who presented with poor urine flow. I was unable to insert a 16 French cystoscope, and her urethra could only be calibrated to a 6 French Clutton dilator. And this patient responded very well to gentle dilatation of the urethra. As long as the dilatation is done in a gentle manner with no bleeding, which will cause fibrosis. Similarly, another post-menopausal woman with poor urine stream for 3 years presented with characteristic uroflow and urodynamic findings. And her cystoscopy showed that she had strictures at multiple levels. Now, during her initial cystoscope, I found that she had excoriation over the vulva as a result of menopause. She was prescribed estrogen cream. I was unable to insert the 16 French cystoscope because she had a stricture at the mid-urethra. However, this stricture was soft and could be dilated, both with an S dilator and a clutton, but only up to 24 French. Her bladder was trabeculated. Now, she did not want any major reconstructive surgery, and therefore, even though she was in self-dilatation and found that the urine flow reduced again, I further dilated her the second time, and I found that the 14 French was snug and the 16 French was tight, but the mid-urethral stricture was no longer there. I did a urodynamic for her, which showed a typical high PDAC Qmax with a box flow pattern on the uroflow. And this patient, when I repeated the cystoscopy for the third time because she declined any urethroplasty procedure, I found that the meatus remained tight while the other strictures were no longer there. And in this patient, I did a meatoplasty with a Heineke-Mikulicz principle for a short meatus stricture, and she remains well post-op. Now, the long outcome of the patients under my follow-up over the past 3 years, all women could void after removal of the urethral catheter. Some had urgency incontinence in the immediate post-op period, and this was initially managed with anticholinergics and resolved after a period of time. 2 patients presented at 6 and 18 months with decreasing urine flow. There was always a preceding UTI, and cystoscopy revealed a flimsy membrane, which was dilated, and none of these patients are on any self-dilatation regime. Now, when we look at to answer the question of how far we have progressed in the management of female urethral strictures, I feel that the current challenge in the management is a problem of diagnosis rather than treatment. Urethral strictures should really be considered within a wider context of female bladder outlet obstruction and voiding dysfunction. This particular paper was a response to a large case series on female urethroplasty. Doctors who manage, and what the doctors who published this paper cautioned was, doctors who manage women with female urethral stricture should understand that there is no standardized definition of a female urethra and what constitutes a stricture. It is very difficult to differentiate this from anyone with a voiding dysfunction, and it is first important to diagnose the condition correctly before considering any surgical options. This is why when this particular young woman was referred to me for acute urinary retention, I performed a urodynamic study which showed very poor urine flow, a high PDAC max, but in this particular patient, she also had an EMG which showed some activity during her voiding phase. Now, what happened with this particular patient, even though her urethra showed some tightness and gripness when I performed the cystoscope, her uroflow pattern actually shows more of a dysfunctional voider who has poor pelvic floor relaxation rather than someone with a urethral stricture. Therefore, this patient is on intermittent self-catheterization to empty her urine and to empty her bladder rather than a surgery. Now, to conclude, my approach to patients with female urethral strictures, I offer surgery to patients with poor urine flow or urinary retention, they have a box flow pattern on uroflowmetry, when the etiology is consistent. I always start with cystoscopy and urethral calibration and map the suspicious areas of the urethra. If there's a meatal stricture, I offer meatoplasty. But for long and multiple strictures, where it is obviously fibrotic and did not respond to prior dilatation, then my approach of choice is vaginal sparing ventral inlay buccal graft urethroplasty. And with that, I thank you for your attention and for having me here.
Yeah. Okay, very thankful to Dr. Paksi and Dr. Punkodi for the excellent talk. Now we have time for Q&A. I'd like to invite any questions from the floor.
See, this is Weda. Thanks for your talk. Very comprehensive. Paksi, I want to check you. There's some reports of treating, lichen sclerosis with buccal graft. What's your experience with an exposed, externally exposed buccal graft? How does it heal? I have never done it.
Thank you very much. It's a great honor to be part of this session. Thank you very much for having me. It's a very lichen sclerosis is a very challenging condition. I just want to confirm. What do you mean in which condition of lichen sclerosis? Whether it affects the glans penis or also the urethra?
For example, when we do glands resurfacing or treatment of any adhesions externally exposed, Yeah.
So, buccal mucosal graft is one of the perfect material for glans resurfacing, especially for lichen sclerosis. We also had the series with Dr. Nikolowski from Syracuse. It's a multinational series when we do a glans resurfacing, and also the buccal belt. There's a nice publication. It also it gives a very good result for the patient. It decreased the rate of inflammation in the glands, and the patient satisfaction is very high. So buccal graft is a very good material for glans resurfacing. Even there are some other experts who would consider that the glans is more similar to the skin. So many other colleagues are doing glans resurfacing with the skin, but both material is basically good for glans resurfacing. For lichen sclerosis who affected the urethra, there is no way we're going to use a penile skin. So we do use a buccal mucosal graft or oral mucosal graft to repair the urethra. That would be my answer.
Thanks, Paksi.
Any questions for Dr. Nagapan? Dr.
Nagapan Legat here from SGH. Just very glad to hear that there's agreed problems with urethral stricture as well as concurrent voiding dysfunction. So how often do you actually perform video urodynamics to exclude problems of bladder neck contracture, bladder neck stenosis, or primary bladder neck obstruction, or even external sphincter obstruction concurrent with urethral stricture?
Hi, Dr. Ng. Thank you for that question. I would perform a urodynamic on anyone who does not improve with urethral dilatation, because the initial treatment is always urethral calibration and gentle urethral dilatation. And if they don't respond or their symptoms don't improve even for a short period of time, I would perform a urodynamics.
Does that mean if after dilation the patient flow is perfectly normal, you will not need to do urodynamics?
No, I wouldn't do a urodynamic, and especially if the patient's perfectly fine, and then say a few weeks or a month down the line the symptoms recur, and when I do a cystoscopy I see characteristic findings of whitish urethra or a fibrotic urethra, then I'm unlikely to perform urodynamics.
Actually, Dr. Nagapan, Trisha here. I've got a question for you. Yeah, I was wondering about your continence rates, specifically stress incontinence rates when it comes to placing the graft in a ventral approach? And if so, if the patients do have stress incontinence, does this subsequently affect your choice of treatment for their stress incontinence?
Okay, so I feel that the risk of stress incontinence is less with the ventral inlay compared to the dorsal approaches. I have patients who come to me with some urinary leak, but when I speak to them, it is always urgency. And this is something similar when you have patients with male urethral strictures who have had chronic bladder outlet obstruction for a long time, or a TURP for somebody with long-standing bladder outlet obstruction. Immediately after the procedure, they do complain of urgency and urgency incontinence. And I think these women have a similar problem. So I manage them with anticholinergics. And the patients that I've had, I've been able to stop the anticholinergics after about 6 months. So stress urinary incontinence I haven't seen so far. And even the longer case series by P. Nayak, they recently published their long-term outcome. They don't really report stress urinary incontinence.
We'll now move on to the next session.
Thank you.
Can I moderate from here? Can we invite Dr. Nagapan again to give her second lecture on adolescent urology?
Thank you. I think the next one will be pre-recorded. I'll just wait for the pre-recorded. Good evening. Adolescent urology is an established field in developing countries, but an emerging field in our part of the world. The problems that you can encounter among adolescent patients include problems of adolescence, problems such as phimosis, penile curvature, undescended testis that was missed when the child was much younger, varicose veils, and voiding dysfunction. Or you could see children who have survived childhood congenital anomalies, mainly because of improved pediatric surgical care, and then they reach adulthood and they land in the hand of the unsuspecting urologist. Now, the scope of the subject is immense. If you look at the amount of congenital anomalies that are present in the field of urology, you can have upper urinary tract problems, lower urinary tract problems, problems of the external genitalia, and complex problems such as exstrophy and epispadias and cloacal anomalies. So most of these patients may be missed during childhood, or they may be emerging into adulthood, and the adult urologist would be expected to manage these patients. Now, does this field pay? Well, this is how most of our robotic surgeons come to work, and this is how I come to work. So if you measure a worth of a person by what he has, then maybe this field does not pay so well. But if you measure a worth of a person by who he or she becomes, then I would say that this field pays immensely. Now, who should be managing such patients? Ideally, a urologist who's able to pay attention and focus on these complex group of patients. Someone with a strong background in pediatric and reconstructive urology, because our work is a lot based on embryology and pathophysiology. Someone who's able to see patients as individuals and works well in a team with nephrologists and plastic surgeons, and somebody who's able to see connections between problems of childhood, adolescence, and adulthood. Now, while the patients who have complex congenital anomalies are the ones that I find challenging and enjoy managing, I do understand that I'm speaking to a general group of urologists, and it's more important to deal with simpler problems that emerge during adolescence. So by the time a boy reaches adolescence, the foreskin should be retractile. So if some child comes to see you with a non-retractile foreskin, you would have to offer him circumcision or a preputioplasty. So this is a paper that was published in 1968 by Oster, and it shows that by the time a child reaches 16 to 17, most of the patients have retractile foreskin. And on this side, you see a picture of a person with a pinpoint foreskin meatus, safe of a pathological phimosis. Now, when it comes to pathological phimosis, we have guidelines from the World Health Organization that show that the guillotine method or the forceps guided methods or device-based methods are contraindicated, and these should be addressed by first doing a dorsal slit. The problem with using a guillotine method is that you may excise excess skin. And I prefer to do these procedures under anesthesia, because if the foreskin has been non-retractile for many, many years, it is going to be quite adhered to the underlying glands. Now, another problem that you can see is penile curvature. As you can see here, in this particular child, the penis, there's some sort of curvature in the penis due to adherence of the ventral shaft skin. And in this child, the penis was degloved, and this ventral shaft skin, this post-scrotal junction skin was dropped down, and what you have is a improved cosmetic outcome. Now, as far as undescended testis is concerned, we looked into our own patients several years ago and found that almost half of our patients are referred late and they undergo surgery much beyond the recommended age of 12 to 18 years. Now, the relative risk of having testicular cancer if an orchidoplexy is done after puberty is 5 times the normal population. But then again, we seldom remove the testis in someone who presents during adolescence with undescended testis because we do want the hormonal function. So we do perform an orchidoplexy because this allows the testis to be placed in a position that allows palpation and early detection of cancer. This UDT should be treated because there's also an association with inguinal hernia as the child grows older. And in patients with impalpable testis, the recommended procedure is a laparoscopic Powerless defense. For example, you can see here a 20-year-old man who presented with impalpable testis. A diagnostic laparoscopy shows that the testis is found in the abdomen, high within the abdomen. So lateral mobilization of the peritoneum was performed. The gubernacle structures were released. This is the long spermatic cord, and this cord was delivered into the scrotum via a separate pathway medial to the inferior epigastric vessels. Now, on the other hand, you can also do a staged Powerless defense procedure. As you can see here in this patient who was 13 years old with thin belly and high intra-abdominal testis, 2 clips have been applied. And the testicular vessels have already been obliterated during the first stage procedure. And the second stage procedure involves mobilizing the lateral peritoneum to deliver the testis into the scrotum. Now, the third problem that you may encounter among adolescents is varicocele. Now, the indications for varicocele surgery in adolescents differs from adults. While adults, we look at sperm parameters and infertility. In children, the indication for surgery is failure of testicular development measured 12 months apart, or a reduced objective evidence of reduced ipsilateral testicular size. So if there's a discrepancy in testicular size in a patient who is asymptomatic with visible varicocele, then a varicocele surgery is indicated. But the problem with varicocele surgery is there is a high risk of recurrence, and this is mainly due to accessory vessels, which are from the deferential vessels, the cremasteric vessels, and the funicular vessels. Now, what are the causes of varicocele persistence and recurrence? So we have performed retrograde imaging by canalizing the veins within the torber fat. And what we found in this image, this varicocelogram, is that you can see duplications of veins. And this sometimes explains why these are some of the duplications that have already been described by Paharin in his classification. So when one of these veins are clipped and the other one is missed, that is one reason for a person to have recurrence. So apart from that, there's also a possibility of that we have not ligated all the branches of the pampiniform plexus, parallel duplications as we see, and crossover veins which are rare. And this is why, while I started off doing laparoscopic varicocelectomy, I found that there are many accessory collaterals that or parallel duplications that may be missed causing recurrence, which is why I've moved on to microsurgical varicocele ligation, which is the current gold standard. Another problem that you may see during the adolescent period is actually at the cord. Now, the normal spinal cord ends at L1, L2 level. In a patient who had with spina bifida occulta, or someone who had a repair for a myelomeningocele during childhood, or someone with a tethered cord, it is possible that during puberty and growth spurt, the patient has a growth spurt and there's a rapid elongation of the vertebral column with stretching of the cord by scar or a lipomyelomeningocele that drags on the cord. And this traction on the spinal cord can cause mechanical stretching and ischemic injury. And what you would find is patients during puberty present to you with urinary and bowel incontinence. And if that happens, we should examine the back for spinal dysraphism and consider the possibility of a tethered cord syndrome. Now, most patients with PUJ obstruction present during infancy, and where they may be detected during the antenatal period, or they may have had a palpable mass. But on the other hand, when older patients present with PUJ obstruction, the presentation is different. It tends to be abdominal pain and cyclical vomiting rather than abdominal distension or incidental detection of hydronephrosis. Now, this is while in pubertal children or infants, we tend to do open pyroplasty, very small incisions. In most of my older children or post-pubertal children, we tend to do laparoscopic pyroplasty. Now, what you see here, you can hardly, most of these patients have got a lower pole vessel, but sometimes there may be a narrowing. In this particular image, you can see the PJ and the ureter, and one would think that there is no obstruction. But when we do incise the renal pelvis, you can see the intraluminal stricture. Now, our experience in infants where we perform open pyroplasty through 2 centimeter incision, we find that these patients need a long spatulation, which is why even in our patients with our patients who have laparoscopic pyroplasty, we ensure that a long spatulation is performed to ensure that there is no recurrent obstruction. Now, when it comes to duplex kidneys, it is a subject in itself, but the 2 main questions that you need to ask when you have an adolescent with duplex kidneys: does this patient have a urethral, or does this upper moiety of this patient, is the upper moiety of this duplex kidney functioning? And we also like to know where the upper moiety tends to end, whether it has a urethral, an ectopic ureter at the bladder neck, which will cause obstruction, or into the vagina, which will cause sweating. Now, what we've dealt with so far is the problems of adolescence, and there are many more which we cannot cover in the next 15 minutes. But maybe I could just share one patient who had a complex problem, who presented in a pretty benign way, just to give you an idea of the kind of patients that we see. Now, this 19-year-old boy presented with recurrent severe left testicular pain, and he was treated as epidermolysis. Now, he had high-grade fever, lower abdominal pain, and an ultrasound showed a bladder stone with a creatinine of 220. But what is important to note is this patient had prior bladder exstrophy and epispadias repair. Now, a cystoscopy done by a neurologist at a general urology center showed bladder neck narrowing, which was dilated. And he was referred to us for bladder stone management. Now, when it comes to exstrophy, the outcome or some of the reasons why patients may develop complications really depends on this bladder template. So if you have a large bladder template, the patient will have good bladder volume, capacity, and pressure. But on the other hand, if you have a small bladder template, okay, even though it is closed adequately during infancy, you may find that when you do a urodynamic, when the child reaches a certain age, like in this particular 19-year-old, his bladder capacity is only 78 mils when he gets severe pain. The fact that he had a bladder outlet obstruction from a stricture due to multiple procedures at the bladder neck for his continence meant that he wasn't emptying his bladder completely. So after extensive counseling, the patient underwent bladder augmentation with Mitrofanoff channel and left redo orchidoplexy, mainly because his testis had ascended due to recurrent epidermolysis. Though he had a stormy post-operative period where he had a leak from the bladder neck because of fibrosis and scarring from previous bladder outlet surgery, his wounds eventually healed. And now he's able to contain much more urine. He does his intermittent catheterization every 6 hours, and his creatinine too has now improved to 114 micromole per liter. So we did look into our own patients with complex congenital genitourinary anomalies. And what we found is that most of our patients had upper tract dilatation, as quite a number of them had chronic kidney disease. They initiated self-catheterization with some difficulties, and some had bladder stones. They needed Mitrofanoff revisions. So a majority of our patients underwent surgical interventions, and these included interventions for dilatation of the catheterizable channel, creation of the catheterizable channel, and bladder augmentation. And what we concluded based on our own patients is that almost half of our patients develop CKD due to poor bladder emptying, and aggressive or preemptive management with catheterizable channels would have actually made a difference in preventing them from going into chronic kidney disease, which is why catheterizable channels are something that we are very keen on performing for a lot of our patients. If there's an appendix, you can do a Mitrofanoff procedure. Without an appendix, we prefer the spiral Monty or the spiral Casale Monty compared to a young Monty, mainly because there's less risk of obstruction during catheterization in the midline. And similarly, we've also used the sigmoid colon to create a Monty in the sigmoid, to create a catheterizable channel, as well as in patients with chronic constipation who need manual evacuation. We can even use the sigmoid to create a antegrade continence enema channel. So these are options that we offer to our patients as they grow older. Now, apart from the medical issues, what we also found among our older patients is that there's a lack of formal education because they tend to go into the special school system. And what we need to remember is these patients with complex congenital anomalies need to integrate with others. They also aspire to have jobs and independence. And the role of the adolescent urologist is to become a bridge between patients, compared to the time when they were children, where the doctor mainly spoke to the mom or the parent, versus the time when they reach adulthood, where they are expected to make decisions for themselves. And what we tend to do is prepare the child for the road by explaining to these children during the adolescent period, in the presence of their parent, about their congenital problem, the kind of surgeries they need to go for, and what kind of quality of life that they can expect, and how we can improve their quality of life and ensure that they don't have chronic kidney disease. Now, another problem that we find is the main reason why they're lost in transition is because there is lack of access to care, especially for patients in our part of the region who are from remote areas such as the east coast of Malaysia or the East Malaysia, and access to information that help is available locally. So with that, I conclude. Congratulations on hosting a successful conference, and warm wishes from Malaysia.
Agapan for such a mammoth job of covering the whole adolescent urology syllabus in 20 minutes. We will keep the Q&A after this lecture by Dr. Yap Tilu. Dr. Yap Tilu is a great friend of ours, and all our residents in urology in Sing Health knows her. She is a pediatric surgeon based in KK Women's and Children's Hospital in Singapore, and she's a senior consultant who specialized in pediatric urology and surgery. And Tilu would like to give us a lecture on essential tips on endoscopic treatment of UR.
Hi, thank you, Leguat, for the kind introduction, and the committee of the UROFAIR for the invitation. Sorry, access the slides. Hi, yeah, I have no conflict of interest. So just a quick overview of the cycloureteral reflux, which is the retrograde flow of urine up into either one or two or both ureters and the kidneys. This is one of the commonest congenital anomalies in children, that if the patient has it, there's an increased risk of urinary tract infection, renal scarring, and there may even be coexisting congenital renal hypoplasia. So incidental findings about 1% in the peds population, but in children with UTI, the incidence can be as high as 30 to 40%. It's important for us to differentiate between primary versus secondary reflux, as the management can differ. So the goal of management, of course, then is to prevent urinary tract infection with the subsequent renal scarring, renal hypertension, and chronic kidney disease. But there's some peculiar thing about reflux that we should be aware of, because we want to minimize the the morbidity of long-term investigation and follow-up. So reflux is diagnosed on MCU, maturating cystourethrogram, grading on 1 to 5, with 5 being the most severe. And the most peculiar natural cause of VUR is it can't resolve spontaneously on its own. But the resolution rate does varies between grade 1, 2 versus 4 and 5. So you can be as high as 90% for grade 1, 80 for a 2, but it's only like 25% for grade 5. So we come to the options of management. So to put things into perspective, you can have active surveillance, which is the AUA guideline recommendation from 2016, and that involves even grade 1 and grade 2 VUR. You can choose, the parents can choose to go on continuous antibiotic prophylaxis. Endoscopic injection treatment is an option, and of course you have the open surgery, laparoscopic or robotic urethral reimplantation. So Endoscopic treatment for VUR is the injection of a bulking material to elevate and close the urethral tunnel as well as the urethral orifice to coapt it. First described in like 1981, and it has been popularized by Plenary, and the original technique is the stink. So this is one of the very high-end, reviewed of a randomized controlled trial in children. They ran about 200 kids between 1 to 2 years old with grade 3 to grade 4 reflux. And it's proven and shown that endoscopic management is superior to both prophylaxis and active surveillance. So with that in mind, we would like to introduce more about the endoscopic treatment, ET, of reflux. It is day surgery, ambulatory procedure, only cystoscope, short operative time. It can be as short as 15 minutes. I think somebody mentioned missed, take 15 minutes. Low complication, reduced cost, and it can be easily repeated. Only caveat is the success rate can range very, very widely from 50 to 100% versus a very assured success rate for urethral reimplantation of as high as 95%. But still, American AUA and the European side both recommend that should the kid on continuous antibiotics developed UTI, they should proceed for either surgical urethral reimplantation or endoscopic deflux. So this is our experience in KK Hospital. So the kid has to be under general anesthesia, and we like to put them in a lithotomy position with the legs up so that we can swing the cystoscope beneath the thigh for a laterally placed urethral orifice. So we use a 9.5 Stinger scope with a 5 French channel and a 5-degree angle of view. And we use the metallic needle. So one interesting thing that we should learn about the needle is the different marking. So the bevel itself is 3 millimeter. The first line is 6 millimeter, and the second line is 8 millimeter. We know you need to kind of know that so that when you inject or when you insert into the mucosa, that's the length that you need to stop. So before you start, you need to prime the needle with the normal saline, followed by priming with the deflux. So the technique that we use, so initially is the stink, which is a suburethral injection beneath the urethral orifice. Then subsequently we developed the hydrodistension intraurethral injection. And if you do both of them together, you have a double hit. So this is what we do usually. So patient will be, we have the cystoscope inserted and the bladder half empty. And we'll do a hydrodistension grading before we start. We find that this grading system has quite a high inter-observer correlation, and it correlates with the VUR grade. So if you have if you have no distension of the orifice, it's H0. H1, it opens, but you can't see the tunnel. H2, you can see the intramural tunnel, and H3, you can see the extramural tunnel. And so this is what a stink is for. You insert the metal catheter 2 to 3 millimeter below the urethral orifice, and you slowly inject the deflux or material that you use. So before you complete, you can see the shining, blotching of the mucosa, followed by the light reflection. So then we close and coapt the urethral orifice into a crescent shape. For the hydrodistension, then we have to distend the ureter. So with the water jet, and we'll place the needle into the mid-ureteral tunnel to inject. So you can see the mid-ureteral tunnel is now elevated and coapt. So we also have the double heat technique, but for this is likely a combination of both. So for this, first step is the hydrodistension. Sorry, the video is a little bit slow. So you can see the jet So what we do is we place the water bag about 1 meter above the symphysis pubis, and we ask the attendant or nurses to help us to press on the bag. So we create a water jet to open the ureter. Then after that, we will do the injection inside. So the first step of the double hit is actually like a hit, and you will see that the deflux material slowly blow up the lumen. Then this is what it looks like after the first hit. And after we pull out the needle, then we'll try again on the outside, which is like a sting about 2 millimeter or just at the edge of the urethral orifice, and that gives the second hit, which will close up the urethral orifice and let it form a crescent shape. So we do have some technical challenges when we do this. First, not that easy sometimes to hydrodistend all ureter. So despite, you can see the fluid and the pressure that we create, sometimes we couldn't distend the urethral orifice. And secondly, we need to turn the needle around so to be parallel to the floor of the tunnel. And even if all this we can do after you inject, you can still sometimes notice a huge gush of the extravasation of the material. And you can see, or the deflux of the material is all leaking out. So when we compare the overall papers on stink versus heat in a systematic review, we find that the heat has actually a better success rate versus the stink, and is for both low and high grade. So currently the trend in the USA since 2014 is double hit for almost all of them. So we do also have to look out for complications. So for urinary tract infection, renal colic after the injection, urethral obstruction, thank goodness it's really not that common, and also cause some gross hematuria, acute urinary retention. So sometimes if we do both sides, or it's a difficult procedure, we actually have to put in a IDC indwelling overnight. And we do have a low risk of a contralateral reflux. So having said all this, I think we will look at some of the predictors for success. But because there's so many variables when we're doing the reflux, we do have to consider quite a number of them on top of the technique that we use. So what we found is preoperative reflux grade. You can tell grade 1 is almost 90% success, but it will drop to 60% for grade 5. And the unusual thing is that it's not a linear drop. You can see that between grade 1, grade 2, and grade 4 and grade 5 has a similar behavior. And the other things that we need to look out for is the structural as well as functional abnormalities of the bladder. And FDA did caution if you have a bladder diverticular, urethral seal, or active voiding dysfunction, ongoing UTI, you should not do endoscopic treatment. So for diverticulum, we can show that its outcome is really not that good. It's almost as good as extravesical urethral reimplantation, though, but for the intravesical, it's much higher. And some of the positive factors will be you should really pick the type of diverticulum. So the ureter should not be inserting into the diverticulum. The size of the diverticulum should be approximately the same size as the ureter. And then we also come on to duplexes. So duplicated ureters, from a systematic review, you can tell that the success is also very variable. So it depends really very much on the surgeon and how they risk stratify the patient. So, but still, the duplex ureter, doing endoscopic treatment is still better than antibiotics. Just that we also run into this trouble. We are not able to diagnose a duplex system preoperatively, despite ultrasound, DMSA, MEC3, or MCU. We miss about 18%, and that is concurred with other center. So neurogenic bladder is the other condition that we do endoscopic treatment. Good short-term results, almost as high as 86%, but it's not sustainable. So it's very important that if you're going to do this for neurogenic bladder, you need to pick the patient. Low VOR, great, and on the urodynamic study, there's a good bladder capacity, good compliance. You do need to watch out for UVJ obstruction though. For the kiddies population, of course, bladder bowel dysfunction is a big issue. They either have underactive, overactive bladder, or with constipation. So the AUA guideline now is you have to manage the patient with the bladder and bowel dysfunction with training before you are allowed, before you go ahead with the endoscopic injection. Because with BBD, the success is only 50% versus 90% without. So we also look at the different type of bulking agents that we can use. Of course, the best would be like it is biocompatible, non-immunogenic, non-carcinogenic, with no migratory risk. So we started off with Teflon, but it's already abandoned because it has migratory risk to the brain and the lung. Bovine collagen is also abandoned, autologous tissue abandoned, macroplastic abandoned. So now we only have dextroaminase hyaluronic acid, Reflux. This is the only FDA-approved material that we can use for kids for grade 1 to grade 4 reflux. So it has a microsphere, which is about 130 micrometer, and that reduces the risk of migration. And a big study, systematic review, but with a short follow-up period of only 3 months, Reflux has a success rate overall of 77%. So but it's not sustainable. Over time, it may drop to 50%. But in one of the observational studies, with like 15 to 25 years of follow-up, it does well for grade 4 reflux. So the other type of material that use are ventrous. This is introduced in 2010 and used in Europe, but higher incidence of obstruction. And this BAHG, which we use for female incontinence, we have also been tried for endoscopic treatment. So the other thing is injected volume. Of course, higher grade, you're expected to have higher volume. We will recommend at least a 0.8. So in the Reflux pamphlet, they actually recommend not to go beyond 2.6 mil. So what happened with transplanted kidney if you go ahead with Reflux or endoscopic treatment for VOR? Chances of success is low at 36.8%. So our KK experience, which is done by one of our colleagues way back in 2015, we have 56 patients with overall success of 89.7. So in a long-term review in the States, parents are pretty satisfied, 94% highly satisfied. So what is the learning curve? So they monitor 2 UROFAIR, and it takes them about 36 patients to hit an 80% success rate. Then the other thing is, can we share our technique with the adult urologists? So again, the UROFAIR did it for adult, and they have a good success rate, which is as effective as the PEDS practice. So in conclusion, I think the important thing is individualized and risk stratification, your patient technique. But otherwise, I think endoscopic treatment is a valuable and viable option. Thank you very much for your attention.
Thank you, Tulu. Are there any questions for both doctors? Well, if not, it's mandatory that we have to ask a question. So, Dr. Nagapan, it's very interesting that you actually adult urology trained and you then went on to do pediatric urology. And over here in Singapore, our training system is a bit different. So, pediatric urology are pure pediatric surgeons like Dr. Yap. And I get this not so attractive task of handling their patients that they have painstakingly looked after over the years and passed to me. And I have this issue, and there's a problem with trust, because they see Dr. Yap for the last 16 years, and all of a sudden, no, she can't see them anymore, and I have to see this other woman who they don't trust. So I'm not sure whether you have the same problem, or do you inherit cases from the pediatricians, pediatric urologists, and how do you handle this?
Thank you, Dr. Ng. I know in UK and Europe and most of Malaysia and Singapore, pediatric surgeons tend to take on the pediatric urology work. But if you look at North America, Canada, US, you would realize that most of their pediatric urologists are actually urology trained. So they do their fellowship in urology, and then they do a 2-year fellowship in pediatric urology, and then they concentrate and become pediatric urologists. Now, I was inspired by Ms. Susan Wu. I think both of us at some point wanted to become pediatric surgeons, but urology was much more interesting, but we still liked working with children. So I think we followed more the American system where, urologists eventually do fellowships in pediatric urology and take on the work. So a lot of our patients are actually children. We see children from infancy. So we're kind of used to talking to the children and talking to the parents. And so probably half of our workload is actually children who have been following up from the time they were kids. But yes, we do have patients who are referred to us as they grow older. I think the biggest challenge I find is that the parents have always been making the decision for them. And now what we try to do is we get the child involved in making the decisions. No doubt it is difficult, but I think as you keep seeing them, they will also begin to trust you and trust whoever is managing. Because I think what's different is that, pediatric surgeons, they tend to focus on the parent, while as they grow older, you need to get that child roped in. And that will help you, get your message across.
Yes, thank you. The other question I was having was, do you find that there's a difference in bladder stone incidence for patients who do self-catheterization after, say, augmentation cystoplasty per urethra from the native urethra versus Mitrofanov?
Yes. If the patient still has a native urethra, sometimes they catheterize from the bottom or the top. But those who have a channel, especially boys, they tend not to have, sometimes their bladder neck has closed. So yes, there is poor bladder emptying, and they do get stones over the long period of time. Yes, that is there.
Sorry, we kind of train them to do bladder washout themselves, like about 2 to 3 times a week minimum. Yeah.
Yeah, despite the washout, I think that there is still incidence of stones. And of course, after when they come over, when the parents wash their hands off them and they start doing their own catheterization, they probably do neglect some of these instruction that was given to them. Yeah, maybe we should ask Tilu. I noticed between stink and hit, you seem to look at the hydrodistension grade to decide, or do you use the VUR grade to decide?
We use the VUR grade because hydrodistension, even though we use it, or rather in KK we use it a lot, worldwide there is still a bit wary about inter-observer correlation. So yes, we use more of the VUR grade when we're doing the systematic review. Yeah. Thanks.
Is there any other questions? Well, if not, then sounds like we have the end of the UROFAIR. Dr. Lau has something to say.
Oh yes, thank you all the speakers. Thank you, Dr. Yap. Thank you, Pugodi. The UROFAIR symposiums have not finished. There's one more symposium at 6 p.m. at M Hotel. So we do hope that everybody can be there, and that will be followed by the Congress dinner. So Congress dinner is complimentary if you have already all RSVP and registered. Oh yes, there's a bus that leaves in 2 minutes. And there's another bus at 5:30. Yeah. So there's a bus that leaves in 2 minutes, and there's a bus at 5:30 as well. So in case you are drinking and you do not intend to drive, that's the better option for you. All right. Thank you so much. Thank you. Thank you.